I will now call to order the regular session of the Watson Community Hospital Board of Directors meeting for Wednesday, February 25th, 2026. Please give us a roll call.
Yes, Director Friel? Here. Director Gallagher?
Here.
Director Pimentel?
Here.
Chair Nunez?
Here. Okay. We have nothing to report at tonight's closed session, so I'll move us on to any agenda modifications for consideration from staff. Okay, seeing none, I'll move us on to public comments for matters not on tonight's agenda. We'll start online. Rosie, anyone wishing to speak on an item not on tonight's agenda online?
No, hands online.
Okay. Anyone in person wishing to speak on an item tonight's not on tonight's agenda? Okay. Seeing none, I'll close down the public comment and I will bring it back to our board members for any comments from the board members.
So I don't know if people saw the news this week, but the County Office of Education passed an ordinance about ICE and not allowing them to use any county property. And I would really like for our hospital board to think about that as potential ICE activity may increase over the next few months, to preemptively say that our large spaces that we have cannot be used for activity for the federal. And I know that the county has done that recently, as well as other cities across our county. And I think it would be a good idea for us to discuss that maybe at the next board meeting, because we have to maintain support for our visitors and for our staff and ensure safety. So I'd like to say maybe we can put that on the agenda next.
Yeah, definitely. Thank you.
Mm-hmm.
Any other comments from the board members? No. I will piggyback onto that. Yeah, so I believe it was the last meeting we had District 4 County Supervisor Felipe Hernandez come in and say that the county was going to take that step. And it's great to also see that the County Office of Education also take that step, and I believe the city of Watsonville as well has taken. And so earlier today, just as part of my employment with Community Bridges, we lead the Immigration Coalition, and so we're happy to. We were asking other partners in the area, what is the right resolution language to bring that forward to the hospital board. As I got a request during that meeting to possibly do the same thing. So yes, I'd love to work with staff to bring something like that and work with both Supervisor Hernandez and then also Supervisor Martinez, who are part of the County Santa Cruz's SHIELD ad hoc committee to bring something forward to that. So thank you for bringing that up. And I totally 100% agree.
I can certainly work with council on that. Noel, my guess would be that this would be a district item, as the property is owned by the district and the district is the public entity.
Yeah, that's a really good question, but it's operated by the hospital. So we'll need to give that some thought if that's a hospital policy or a district policy.
Okay. If there's no other questions, or I'm sorry, if there's no other comment from the board, then I will move us on to the consent calendar. Okay, I'll move us on to the consent calendar. I believe we have 3 items. Yeah, 3 items on today's consent calendar. One is a minutes approval for our meeting in January 28th, 2026. The second is policies summary approval for February 2026. And the third is the California Department of Healthcare Access and Information, HCI, Hospital Distress Loan Program. There's a resolution there to authorize our CFO to execute a second amendment to that distress hospital loan. Is there any questions on these 3 items from the board before I go out to public comment? Okay, I will go out to public comment on the 3 consent items. Anyone joining us online looking to comment on either of these 3 items?
No hands online.
Okay, anyone in person? Okay, seeing none, I will close down the public comment. I'll bring it back to the board for any, for an appropriate motion and of course, any final comments and deliberation.
No comments, I'll move consent.
Second. Thank you.
Thank you. Directors Pimentel and Gallagher, I'll take roll on this item. Director Freel?
Yeah.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
And Chairman White.
Yes. Okay, we'll now move on to the medical executive committee's report of approval for January and February 2026. This is a report that we received in closed session from the medical executive committee, executive sponsor, Dr. O'Grady, as the chair of the NBC. Any questions from the board about this report before I go out to public comment? Okay, seeing none, I'll go out to public comment. We'll start online first. Anyone online wishing to speak on item number 4, the MEC report?
No hands online.
Okay, anyone in person? Okay, seeing no hands raised, I'll close down the public comment and bring it back to the board for an appropriate motion.
I'll move approval, just comment that we're approving 2 months worth of credentials, January, February.
I'll second.
Thank you.
Directors Pimentel and Freel, and we do have the agenda noted. It's for January and February. I'll take roll on this item. Director Freel?
Yes.
Director Pimentel?
Yes.
Director Gallagher?
Yes. Yes. Okay, that'll bring us to item number 5. This is a leadership report. And Steve, whenever you're ready, take it away.
Great, thank you very much. We will pull it up and Chief Nurse Trina is gonna kick us off and then I'll go after.
Give me just a moment to show
All right.
this first. Okay, should be good.
Okay, first slide is, I think I've shared this before. This is our delirium team members here. That is a multidisciplinary team. And I shared this, I believe, a month or 2 ago. They were selected by Beta Heart, our insurance carrier, to give a presentation on their work that they did for delirium. And now they were just recognized by the Joint Commission. And the Joint Commission is using them for they want to use their study as one of their resources for best practices and safe practice. So I just felt like it was really important to bring this to everyone's attention, because despite all the challenges that we are currently facing, it does show that our staff care and that they are providing, excellent care to our patients. So congratulations to the team and great job to everyone involved. In their delirium study, one of the things they did in their initiative was identifying that we were not doing delirium screening very well, and we didn't really have any identified treatment protocols. So part of their work was selecting some evidence-based tools. They assessed the staff's knowledge and what education needs needed to take place. They did a phased implementation. They received a lot of patient and family engagement as well. And they collected all the data, and the results were a 19% reduction in mechanical ventilation duration and a 48% reduction in restraint hours, which is really significant. So great work. We also were able to use this kind of as a catalyst for other areas of the hospital as well to, improve our care and treatment for our patients. So again, just, wanted to share this, thought they all did a wonderful job, and just, it does show that we are providing good care here. So thank you. Workplace violence prevention, we are still really working on that. We've had a couple more incidences on our campus, unfortunately. One of the things that we identified last time was our BOLO alerts. And we were able to remove the barriers that were prohibiting us from getting those bullet alerts out in a timely manner. And I'm happy to say that with these last couple of incidents that happened, we were able to get those out very quickly. So it's working. We were supposed to have a risk assessment done by Beta this month. Unfortunately, because of the storms back east, that got delayed. And so we're still pending a time for them to come and provide this assessment for us, but we're hoping to get this scheduled soon. We're doing a lot of ongoing work with our Workplace Violence Committee. It's a pretty robust committee and everybody's really engaged. With our new employee health nurse, Allison, she has been able to also look into Cal OSHA 3342, into how that is kind of dictates how you communicate and address workplace violence incidences in the hospital. And so she is working very hard to make sure that we are abiding by all of those regulatory requirements. Our Director of Risk and Compliance has been able to take a real deep dive into looking and identifying our knowledge deficit and some gaps that we had where there were some areas of opportunity identified. And so we are working on improving those. One of those areas is an escalation pathway on how to identify patients that come in that, you know, were under arrest or under any kind of legal constraints. And so that actually just got finished this week and approved. So we are also, John Burke, our facilities director, and Robin are reviewing our forensic policy here in the hospital and how we address those patients. So that's getting in the process of being updated as well. We did have a meeting with Watsonville PD and our security company to, again, address any, you know, communication breakdown gaps and how we can improve those. And it was a very good meeting. And then we also met again today with Watsonville PD, and we'll be doing quarterly meetings, just improving our, you know, our partnership with our EMS partners. And then just still providing ongoing support for staff that have been involved in incidences and making sure that we are there to provide the support they need. So a lot of work has been going into this. CCU update, would like to thank all the CCU nurses for, you know, their flexibility in helping us get the schedule covered with our coverage needs. Our recruitment continues. I believe we put out another offer for a night shift nurse, and a second one is supposed to go out today or tomorrow. The one full-time nurse and 2 per diems that were hired last month are off orientation and working. So we have been able to stabilize the schedule. So happy to report that. Surgical services update. We did hire our new director, Amanda Cortez. She comes with over 12 years of experience in the surgical services. She comes locally to us. And so we're very happy to have her on board. She started new hire orientation this week and is already jumping in and getting her feet wet. So very happy to have her. For regulatory updates, we're still in the queue for our Joint Commission visit. And our CDPH survey for our MRI trailer was approved. So yay. Thanks to everyone for all their hard work on that. Nellie, thank you so much. And also to Robin and our quality department and everybody who was involved. I'm sure I missed somebody, but thank you to everyone that was involved with that. So we did get our MRI operational, I believe, on February 12th. And we have been seeing patients. Unfortunately, it is down. We're having some difficulties with it. They've been out for repair. So hopefully we will get that, squared away here shortly. Tonight.
Somebody coming tonight.
Perfect. And that is all I have for updates.
Can I ask, is the city, joint commission follow-up, that's to the things that were required to be addressed, the issues?
That was from our previous site survey.
So this is
Yes,
the
this is
follow-up.
a
Okay,
revisit. Yeah,
thanks.
follow.
Any other questions for Trina before?
You had mentioned about some more incidents. Could you talk a little bit about, you talk about horror plans you opened up, but there's been unfortunately some more.
Yeah, just trying to, there was, in it,
Well, maybe less about what did when or how many, like, the three new.
just two.
Okay.
But two significant instances. I'm pausing because I want to protect the privacy of people, and it was a very sensitive incident, so. But we've had several meetings and we're addressing the issues pretty promptly.
Yeah, people are in the legal law enforcement system, and they need to get medically cleared. They get brought here, and we're working with law enforcement on how to continue to do that in a really safe manner, so that our staff and everybody is kept safe.
Thank you.
So that's, we've had a couple of those opportunities for learning. Thankfully, everybody is okay. I just have, I think 3 slides, and I want to talk a little bit first about, go back and talk a little bit more about HR1 or the Big Beautiful Bill. So Dr. Gallagher helped me put some of this together. Really, what the conversation I have been having lately, I've been having this conversation a lot with elected officials at the state level, locally, and staff members at the state level as well, is in addition to the things that we have budgeted for future years where people will lose Medi-Cal insurance and become uninsured, we'll still take care of them. The impact has already been felt immediately on cash, and that is because the quality assurance fee program, or the hospital fee program, number 9, that we talked about before, has still not been approved. So that normally would have been approved last spring or summer. Had it been approved, then we would have had about $4 million coming to us in the fourth quarter of last year. We had budgeted for that. That didn't come because that program hadn't been approved yet. Plus an additional 10 to 14 million in the first half of this year that we're in right now. So that's 14 to 16 to 18 million dollars, which is about what we benefited from program 8 last year, which was that about 17 million, 18, close to 18 million. And as you remember, we started with 8 days of cash on hand when the district was formed. And so without a robust cash on hand position to fall back on, that 14 to 16 million dollars of lack of funding coming in because of no pot 9 has really fallen on the backs of our vendors and our service providers. And so we have a 13 to 16 million dollar accounts payable outstanding balance, depending on what week you're looking at it, or what time of the month it is, based on when the invoices are coming in and going out. So this is the conversation I'm having with our officials to see if this is not a problem that the state created, but I'm asking the state to help us solve it. Even if it's in the form of a short-term loan, so that we can get some of these things paid and get up to date with our outstanding invoices and debts. As you know, we've used our line of credit, so we don't have anything left there. We're also trying to get that increased so that we can continue to draw on that. But in the meantime, this has been a large part of my regular day, is talking about this with various groups. One program that is very related to this is the distressed hospital loan program. As we thank you for approving in the consent agenda our application to have the first year of the 2023 distressed hospital loan that we received forgiven. We're in the application process with the state right now. We anticipate that that will be approved. We will not have to pay that back, at least for the next year. There has been a lot of talk at the state level about kind of recreating the distressed hospital loan program. So there is a Assembly member Soria who introduced on the 12th Assembly Bill 1923, which would turn those previous distressed hospital loans into grants, so they would not have to be paid back at all. It would fund a new round of distressed hospital loan program and would expand the inclusion criteria, which I think would open it up to probably more entities, but would also open it up for us to probably ask for more than we did last time. We actually had one of the smallest distressed hospital loans. There were many hospitals that are smaller than us that got much bigger ones. And obviously with our cash situation and the lack of Quad $9 coming in, that would be very helpful. So we're having this conversation. It's a bill that was just introduced. It hasn't made its way through any committees yet or anything like that. There's also the possibility that some of the language from it could be put into the budget for the June-July timeframe, which could help us as well. So we're working kind of all of those political angles to see if there's a sort of a refunding of the distressed hospital loan program that we can take advantage of, so that particularly just to get us to when Quad 9 finally does get approved and we can start getting those funds coming to us again. And then the last slide is a piece of small piece of the pie, but a good piece of good news financially, and this is related to value-based purchasing. So with the Center for Medicare and Medicaid Services, Medicare reimbursement rates have some of that funding is at risk or has an opportunity for improvement based on your quality and your patient experience. So COPD mortality, heart failure mortality, pneumonia mortality, patient communication and engagement, so the patient experience and safety and efficiency, the state essentially grades each hospital on each of those items on a curve. How are you comparing to all the other hospitals in the country? And that can impact your reimbursement positively or negatively. In 2025, we had a negative $89,200. That much was taken away from our Medicare reimbursement. In 2026, that number goes up to a positive. We get 11,000 more in Medicare reimbursement. In 27, it will actually be 81,000. These numbers are financial data that are based on quality and patient experience data, usually from 2 years prior. So that 2025 number is usually about 2023 quality and patient experience data and so on. So that 2027 is going to be like 24, 25 kind of data. This little graph here just kind of shows, that yellow line is where you're performing if you're just breaking even and you're just getting sort of your normal Medicare payments. We've been able to move the line to the right, and so our reimbursement goes up. And so that's a really positive thing. And it also shows that we've got that much more room to keep it going. If we can continue to improve quality and patient experience, we can keep moving that line up and getting more reimbursement for Medicare. But good to have a nice 3-year trend. Yeah. And that's all I have, and I'll take questions.
Okay, any questions for Steve about his report? No questions. I do have a question. For the distressed hospital loan, the 8.3 that we have, where does that show up for the public's knowledge? Where does it show up on our budget or in our books?
Yeah, it would be on the balance sheet as a liability. It's been a long-term liability since it's from back in 2023 when we received it. If and when we get part of it forgiven, then we'll be able to remove that as a liability.
Yeah, and at that point, you would take whatever portion is forgiven, you would bring it to the income statement, because at that point, you can recognize it as cash, even though we received the cash 2 years ago.
So that would be a great thing for us, for that to be forgiven.
Yeah, for sure. And from a cash flow standpoint, it would mean, starting in May, we wouldn't have to pay the state $154,000 a month. Because that's what the payment would be if we have to start paying back.
Yeah, a new round of the distress hospital loan. It sounds like we know this just from, being in this, for the past 4 years or whatever it's been, but it seems like there are other hospitals across the state of California that are doing the same issues that we are. And
Yeah.
As you said, I think, the largest of the first round of hospital loans was about 55 million over to Merced, if I remember correctly. And so I don't, and I also want to be cognizant of what's happening at the state budget, for this year. And Marcus knows this very well from his work at the county. And I guess I'm wondering how the board can continue to help to advocate. I know, Steve, we've worked very closely together to advocate some of the local and state officials, but anything that the board could do, additional advocacy through potential letter or meeting or tour or whatever it might be for our elected officials, and also teaming up with, if you could talk about how we're at the forefront of working across other district hospitals to help possibly craft the language around the distress hospital loan. I don't know if it's too early to talk about that, but our potential role in that and in the advocacy that we have to make.
Yeah, it is a little early because we haven't actually met to start working on that yet, but I've had conversations with our government relations official at the Association of California Healthcare Districts, who is sort of at the forefront of this in Sacramento with respect to crafting language, whether it's moving Assembly Bill 1923 along or putting some of that language into statute, into the budget process, whatever that process might be that the state is open to doing. We'll get to be a part of that, along with probably another local hospital that's also received a distress hospital loan, as well as likely one of the district hospitals from the Central Valley, where there's a Republican representation, so that we've got kind of an across the aisle, across the board representation in crafting this language.
And then, Joe, you have a question when you're done? Yeah, and then the only other thing was, again, a really great conversations happening here at the local level about how we combine forces as a county and as entities. I know the county of Santa Cruz is extremely supportive, but and I know that they had representation up at the state capitol, I believe, just today and throughout this week, meeting with our Speaker of the Assembly and of course Senator John Laird. From the conversations that I've had, and then just really going above and beyond through CSAC, which is the County's Association for California, of asking the state to backfill some of the challenges there. And so, anything we can do to piggyback off of that, to let them know that, essential to continue to backfill some of the losses at the county. And there was a presentation done yesterday, but for us as well as a hospital, understanding that, if this hospital were to reduce services or close anything down, it would have an extremely detrimental impact to residents across the county. So I know they understand that and want us to be as good of partners as we can to that advocacy that's happening at the state level. So again, any way that we can support as a board.
Yeah, we've got a lot of wonderful support at local and regional levels, which is wonderful. And so to the extent that you're talking with any other, county supervisors, anybody else, let's make sure that we're, it's 100% of people who are in elected spots who are supportive of us and of our mission to try to backfill some of these dollars to get our get that cash flowing to get us to that next step. would be wonderful. So I appreciate that. It's also really important to know when we're advocating and, because it's helpful to know it's not just us,
Right.
right? 17 different hospitals received the distressed hospital loan. 16 of the 17 have continued to ask for it and have gotten it approved to be deferred at this point and are requesting for it to be forgiven. There's only one that's sort of not meeting the criteria for being distressed anymore and gets to pay it back. And they're asking, they're fighting that, right? But we're not alone in needing to continue to have it help us and needing, to ask for another round of it to keep us going, because the way the nation's healthcare system is set up, it's not set up to help hospitals like ours be super successful.
Joe?
It's a question about 2 steps ahead, assuming that we get the forgiveness and that there's a new loan program.
Yeah.
That's really a question for Julie. I remember the discussion around 8.3 million, and it was a sort of robust approach. And then I was surprised to hear another regional hospital got almost twice that. Do you know how it is they approached their application, or do you have any information about what? Okay. Thanks.
I don't have any other questions at this time, but I do want to take public comment for this. Yes,
Any update that the federal funding that California received? The progress?
The Rural Health Transformation Program?
Yes.
Yeah, the Rural Health Transformation Program is definitely we are on the radar for that with our elected officials in Sacramento, and it is very much on our radar in terms of what the process will be there. It sounds like there will be an application process at some point. We don't know what that is yet and when that is due. We do know that the funding will not start flowing from the state to the hospitals until September, October. Yeah. So it's another one of those things that's like, it's a possibility, it's very good, it's very positive for us, and like, we need some help to get there, right? With the cash, or we're gonna significantly move there if we don't get some.
Okay, I do want to open up to public comment on this report for move on to item number 6. Anyone wish to speak on this item online?
Okay, I'm online.
Okay, anyone in person wish to speak on this item? Okay, seeing none, then I'll close on the public comment and move on to item number 6, the Chief Financial Officer of the Finance Performance Center.
Very good, thank you. All right, well, this is the first month of the new year with a new budget. The positive news is that we had a much smaller loss for the month than most every month that we saw in 2025. We did miss budget by $486,000, and I want to address that a little bit by comparing January of 26 to January of 25. And the reason I do that is if we create a budget, which was a $7 million loss for 26, and when we go to spread it out over the months, we do a lot of kind of spreading historically, trying to look for the seasonality. And so I went back to look at, January of 25, because a few things, especially the net operating revenue, kind of stood out for me as 14 million would be a pretty robust month for us. Last January was a pretty busy month for us. We had about 6 more patient days per day, or the average daily census 6 higher. We were close to 36 average daily census as opposed to 30. We had more deliveries, we had more ICU admissions, more NICU admissions, more ED visits. So there was definitely a difference in the volume. when I go to my actual volume slide, you'll see in most cases, we were not that far off of our budgeted volume because this year going into the budget, we were much more conservative about how we budgeted volume, given where we saw the declines after January 25 and especially into the summer and after the passing of HR1. So that gives me some consolation that I know that every month I don't necessarily have a net operating revenue budget of $14 million because a 12, 9, almost $13 million net operating revenue is actually a pretty good month for us. And we did do some kind of extra scrutiny on how we were valuing our accounts receivable because we had a small charge master increase and we needed to make sure that we didn't just assume that every dollar of the new increase would turn into net revenue. And we needed to make sure it was valued appropriately. The one other unusual item in our net operating revenue for this month was the completed payment of the Packard loan. So it was about a $900,000 to complete that payment. And so as we complete those payments, we do revenue recognition. So we were really closer to a little over 12 million without that in that revenue. The expenses typically, especially in the labor or supplies, flexed a bit to budget. So, definitely flowing closer to the volumes that we saw. Pro fees, we have budgeted a larger amount for this year, given some of the new contracts and increases in those contracts, but we were pretty close there. And probably the largest favorable variance in other is the fact that when we do budget for these QAF programs, we budget kind of both an expense and the revenue coming in. Next slide. From the statistics, so here I'm showing you that towards the end of last year, it always felt like there was a lot of red in the variance column here because we were missing by 10 and 15% sometimes on things like admissions due to some of the things we had budgeted for last year. Much closer, basically on budget with admissions, pretty close in patient days. We saw a drop off in deliveries, but as we've seen over the course of the years, sometimes it's just a matter of a month and it swings the other way. And so not too concerned about that, especially as we had a very strong delivery year last year. Inpatient surgeries missed a bit, and some of that is certainly in the areas where we're just ramping up new physicians, such as general surgery and ortho. Outpatient surgeries were strong and at budget. ED visits were fairly close to budget. The outpatient non-ER visits was probably the largest miss, 753. Again, I think a good portion of that is maybe the budget spread, because 3,600, almost 3,700 is a pretty busy month for us. And I don't think all of the months are budgeted quite that high. So again, looking back to what January of 25 looked like. Also, the fact that we had no MRI throughout that month would have also contributed there. Next slide. So this takes the look at trying to bring in the case mix adjustment and looking at it an adjusted discharge so that we're somewhat normalizing for inpatient business versus outpatient and the acuity of our patients. And this is best done on a kind of current year versus prior year to really get a sense of how we're doing. And what kind of throws this one off a little bit as we dug into it is how much our volumes have shifted to the outpatient world. The inpatient volumes, just the way the calculation works, when it shifts, it basically grows your denominator of the calculation between the case mix and that adjustment factor. So, so when we looked at that, but then we looked at, well, how many adjusted discharges did we have last year versus this year? And, there was a decrease there, so it basically made a slightly larger amount of expenses because we have the inflation and some higher expenses over a smaller denominator. Makes it kind of look like this year's numbers are a bit inflated from last year's. So I think this is one where 1 month is a bit hard to compare, but we will continue to monitor it because as we saw last year, when we started doing this calculation, it really did tell the story. Next slide. So our volumes, as I showed there, the admissions were pretty much on budget and kind of climbing back up. We had a slightly higher length of stay this month at 3.5, which is really pretty close to our budget, and not much else to report there. Next slide. From a delivery standpoint, we did talk about the fact that the deliveries were down and also that our NICU admissions, they're down. We had 10 this month. We had 10 in December, but when I looked back at what January of 25 looked like, when we had a higher volume of deliveries at 73, we also had 18 NICU admissions. So those two do somewhat follow, not always. Some months there can be a low delivery but a high admission rate, but they do tend to follow somewhat. So I'm on the ER visits. So we had been seeing some drop off in the ER visits. In January, we did see an increase, and so we were up about 3%. But when you look back to last year, we were down about 6% compared to January of 2025. And when I looked at the ER conversions to an inpatient status, this was a month where our conversion rate was higher than it's been for the last, probably 6 months or so. And so I kind of just drilled into the payer mix to see where that increase was. And it was typically in, or mostly in Medicare and our managed Medi-Cal or the Alliance patients. On the surgical cases, the top being the inpatient, the kind of same top 3 that we pretty much see every month. What we did see here was that the top green there is our OBGYN, and that is typically one of the highest ones, that and general surgery. But this is an area where last January we had done 29 versus 15 this January. The other 2, which is your GI, which is the small blue at the bottom, and general surgery, which is kind of the orange in the middle, they're pretty close to what they were last year, just like within about 2. At the bottom, the outpatient surgical cases, again, we saw the most decline from last year was actually in the general surgery. Wait a minute, I'm saying that backwards because I got my notes here. The green at the top is the general surgery. And so we did see a decline of about 8 cases. Last year we were at 57, this year at 49. We have seen an increase in the ENT cases, and where we saw our largest increase was actually for the month in OBGYN at the 22 cases. One of the things that is not on this slide, but I noted when drilling into it, is one of the other places where we saw some increases is in plastic surgery. That was something that was not very strong last January, and we did 16 cases in this January. I do think that the, as I mentioned earlier, the ortho and the general surgery dips are somewhat related to having new physicians that are in a ramp-up period. Next slide. Inpatient payer mix, about 85% government, and unfortunately, this was a month where we did have a fairly large decline in our commercial mix with 13.3%, which is pretty small commercial mix. We did pick it up in the Medicare at 33%, which is one of the highest months that I've seen as having 33%. We usually are in those high 20s to, maybe 30. So this will be another trend to keep an eye on. Everything else is pretty much in the range that it normally is, and we were at about 40% alliance admissions. Sorry. On the outpatient side, it is very consistent month over month. Nothing really ever changes, and about 75% government, and we're at 22.4% of commercial payers. With that, I will open it up for any questions.
Any questions for Julie on this report? Julie, I want to go back to the, I think it was a slide with the two, that one right there, the ER visits per day conversions to inpatient percentages. I think you had talked about the majority of the patients in that we saw the admittance rate go up, that they were mostly Medicare and Medi-Cal, is that right?
Managed Medi-Cal with the Alliance.
With the Alliance. Okay, are we concerned about that big of a spike from December to January, or what kind of trend should we be looking at in terms of that?
I'm not too concerned about it. I think we were up over 7% conversion, which if you looked back a year or so, that was not an unusual number to be 7-8% converted. It just seemed like in the last half of 25, we were down more in the low sixes,
Right.
6 to 6.5%. So it was a little bit of a surprise to see the uptick. But, thinking about it being winter and,
Right.
potentially, illnesses and things in the community, your Medicare folks, senior citizens.
Right.
And then, with the managed Medi-Cal, I didn't take note specifically of how much of a jump it was. I just looked, quickly at which groups had the higher numbers.
Mhm.
But if you look at our overall admissions, they were up a bit, month over month, but being at 270 or 271 is, that's a kind of normal month for us. We usually, those can be anywhere from 270 to 300. So our overall admissions, it's really just saying a little higher.
Yeah.
Conversion.
I wonder what obviously the impacts of the first change from the state budget to Medi-Cal happening January 1st, and what sort of trends we might see, through the first 6 months of this month, and then obviously, forthcoming changes from that. I just don't know, I guess that's what I'm looking for in something like this, and it's really hard to tell with 1 month's worth of.
Yeah, I won't say it in 1 month, but we're definitely something we'll be keeping an eye on, because
Yeah.
the Alliance has said they've already started to see a decrease in their enrollment
Oh, interesting, okay.
across all of their counties
Right.
in aggregate, so, yeah.
Yeah, and it's one of the things when we work with our early or self-pay vendor, anybody who comes without an insurance, we refer them to try to see if we can get them qualified for anything. So that's certainly something we've asked our vendor about, and ways to try to watch for, if we're sending roughly the same patients, but are we seeing fewer able to convert? Or we've even been watching for the last 6 months, are you seeing a higher non-response rate?
Sure,
Because you don't want to be on the radar.
right.
So there hasn't been a whole lot that's come out of it yet, but they're very in tune with everything that's going on, because they are a local company, local to the state. And so we're trying to mine any type of
Right.
intel we can out of that.
Yeah, it's hard to tell through 1 month. I just, there's some reports and it's the Monterey County side, and so I don't know where this percentage increase is where they saw this percentage increase, but I think the county in Monterey, they reported that they saw an increase, like 16% increase in the number of people who enrolled into Medi-Cal that had, I'm sure it had, all of the outreach that that county did and funded through their board of supervisors and the money they put behind the outreach, whether it was flyering and radios and TV ads, all that stuff, I'm sure had an impact on that. And we've been doing some of that work here, and I don't, anyways, but it's just something to continue to monitor, I suppose, going forward, and number of people coming in. And then the other thing, is ER visits converting into inpatient visits. Medi-Cal folks who have delayed care, who have not been able to access a doctor or whatever it might be, that, that number going up consistently month over month, is something that I would, set off to me that's, I don't know if it would be a delay of care, people come into the ER actually sicker, and now that admittance rate continues to go up. But the 6% has always been like the standard for us, so now it's above 7%. It's like, oh, what's going on?
Yeah, I will say, from a reimbursement standpoint, there is some benefit to us for that.
Sure, yeah.
And because if you think about the size of our hospital, when we talk about our staffing ratios and our capacity, it often isn't having us bring in any more staffing. They're here with an empty bed or, an empty, some ability to care for that next patient that will now be reimbursed at a stronger rate.
Yeah, definitely. Okay, those are, I think, all my questions that I have for this. The other one is probably too early to tell for February, but I don't know if we have a sense, maybe Trini could help with this, the sort of cases that we did not have to send out and that we were able to keep here in the, what's it been, 10 days that we had the working MRI machine. I don't know if what that actually looked like on a 2-week basis that we had, or what
I don't have the actual
Yeah.
numbers. I could definitely get them. Oh, maybe Nellie.
Hi.
I know.
So just in the short amount of time, we had almost 100 cases of MRI, to come around. And we will continue to see those numbers soar as we build that trust within the system.
Yeah.
Just a quick update. We hope to have everything settled by tomorrow, working with the vendor as we speak.
Good, thank you. Thanks for your work.
And I would say just in general, our census has been stronger in February. We're running a higher census. We even have an MCU census that's kind of more normal. So, that volume always helps.
Yeah, the January 2025 was a tough song. So this here, when I saw the report of the packet, I was like, this is not good, but it's better.
Exactly.
And so this is much better, even, taking into account that we're realizing the final payment of the Packard loan and everything like that. It's still like MRI machine gets up, CT scanner in the middle of the year, additional funding coming from state. I mean, there's a horizon at the end of this, I think, which is good. You get to think about how do we get there. That's what we have to address. But yeah. Okay, if there's no other questions I do want to, or any comments that you want to open up for public comment.
I just comment on low, or already low cash balances are.
Right.
And that I appreciate Steve, Julie, Tony, everybody, make sure all of our officials are fully aware of that. I think we need to keep doing that. Yeah, and just keep reminding them that it was a commitment by a lot of parties to turn this hospital around and stop losing $30 million a year. Its last profitable year was like 2015 or 2016. I took it over and we were almost there going into 2025. Expecting 2025, that it should have been the profitable year for us, were not things that started happening to us. I just want to acknowledge your abnormally low cash. We need our partners to understand that, and we need to find some short-term solutions to make sure we can keep all the things, the progress that we've been made going forward. We're just hearing earlier in your CEO report of the turnaround in our quality metrics. And we've been talking about that for a couple of years now. We've got so many amazing stories out of our hospital. I get so depressed on the finance side and forget all these amazing things that we've done, turn this around from a service, community asset perspective. Yeah. That it's just this cash flow is, inheriting, saying inheriting a hospital, with 8 days cash, so it's wild. That started with 8 days of cash.
Yeah.
We haven't been able to make progress out of that. But yeah, we've got a system that, has a, like you put it, a horizon that keeps us there, and if the feds had just done the thing they were supposed to do last part of the spring, not even the president's office, but just the normal process, cash would already have been implemented in October, $4 million, we would have seen in the last quarter of 2025, $14 million for 6 months of this year. That's stuff that just would have happened as the normal staff person in CMS would have been improving itself. It's really disappointing to see that. Anyways, I'm gonna go on a rant. So I don't want to miss that we're managing amazing turnaround with no cash. And we need partners to recognize that and see that this is an amazing investment that bring them to the table. I'm gonna stop there. I'm feeling a rant. So that's questions or more comments.
Yeah. If there's no other questions or comments, I will open up the public comments. Okay, Rosie, any raised hands online which should speak on this item?
Yes, we do have 2 hands raised online. I will ask Carmen Powell to state a comment, please, and we will do 2 minutes, correct, Chair?
Yep.
Set the timer.
Can you hear me?
Yes.
Yes, hi. My name is Dr. Carmen Powell. I'm the pediatric chair for our Watsonville Community Hospital. And so it's great to see this report and kind of the full scale of where we are currently as a hospital. However, I don't know if it's completely reflective of the physician experience or really kind of what we're seeing right now in terms of supply chain issues that I know we're actively trying to address, and then some of the patient care safety concerns that we've brought up to our administration. But I did want to speak, someone brought up this comment about the transfers, because I know particularly for our level 2 NICU, that has been an issue in terms of, not an issue, but rather we have very highly acute patients that do present here, and having to transfer those neonates to a higher level of care, particularly to a level 3 NICU like Stanford or Dominican, when necessary. But my concern as a provider is going into the resuscitations without the adequate equipment, or even concerns of not having enough nursing staff available to appropriately care for those patients when they're needing stabilization. So I know that's maybe not highlighted in the budget or the numbers, but that's a true account of what myself and other providers experience on a regular basis, to the point that some of my providers are very concerned about their capabilities of providing excellent care to our patients in this community. We've already dealt with the closure of our pediatrics because of nursing staffing, and there's been no kind of follow-up about if that should reopen. But I think also I want to just highlight of just payment to different contracts and physician groups, addressing those matters, because that is an issue when physicians are not receiving payment on their services for months on end. And I don't know if that's really highlighted here in the discussion of the budget today. And then also, we have a lot of dialogue and discussion.
Carmen, if you can wrap up your comments.
I'm wrapping up now. As the executive committee, I think we just are requesting more transparency and understanding, particularly from the leadership of both the board and our administration, what direction we're going in, because I think sometimes there is some incongruency there. So that's my public comment.
Thank you.
And we have another hand raised by Mary Boyd.
Good evening. At yesterday's financial meeting, surprise was expressed that we have a lower number of outpatients visit. I was surprised by that because according to requested by administration, ultrasound scheduling has gone from scheduling 3 ultrasound rooms to 2 ultrasound rooms to now where we're only doing 1 ultrasound room and only 12 exams on Monday, Wednesday, and Friday. And this was all supposedly proposed by administration. But if administration doesn't know that we're doing less ultrasounds, where's the disconnect? And in support of the previous speaker, do you know, any of you know the amount of children in our area? Because it used to be pretty high. I thought it was in like the 30%. So when we don't have a pediatric unit, you know, we're missing a big part of the local population that, you know, then has to be spaced out. So you said you were going to be looking at the reasons for less outpatients. Well, there's one reason there for you. And of course, patients don't go for gallbladder surgery without having a gallbladder ultrasound first. So it's, you know, along the line there. And hopefully you guys can resolve that disconnect between administration saying to schedule way less patients and then being surprised that there's way less patients scheduled. And all this with the same number of staff and the same number of ultrasound machines. It just doesn't make sense. Thank you.
Thank you. Anyone else online wish to speak on this item before I go to the public here?
No more hands online.
Okay, anyone in person wish to speak on this item? Okay, so I'll bring it back to the board before we move on to item number 7, the quality report for October 2025. Any closing comments from the board? No.
I do want to acknowledge anytime, especially our own staff and physicians are taking the time at least 7 o'clock at night to participate. I appreciate your voice. I appreciate your input. I'd say, while this isn't a back and forth dialogue in the way this is set up, I just want to know where we as a board are aware of some of our supply chain issues and staffing issues, and those have been discussed previously. But we also understand that we're poised to have a more challenging road if we can't solve for our cash shortfall issue. That's my comment started out of gratitude, so that's where I'm going to end it. Just thank you for participating. Thank you for sharing your voice with us.
Okay, then I'll move us on to item number 7, Wassamo County Hospital quality report for October 2025. Okay,
Not going back in time, correct?
Michelle?
A little bit, maybe.
Maybe a little bit. Give me one moment to share this on the Zoom as well.
Hello, my name is Michelle and I am the Director of Quality here, and I want to do our quality team report. We'll start off with some regulatory activity. Trina already, can go to the next slide, please. Trina already kind of talked a little bit about a couple of these items. So we did get our MRI trailer inspected and we are back in business as of this 12th of February. And Melody is working hard to make sure that that thing stays up. The other thing that's pending with CDPH is a flex waiver for our cath lab that just kind of helps expand some of the procedures that we do in that lab. And then with regard to the Joint Commission, the evidence of standard compliance was accepted. So basically those corrective actions that we talked about last time, they accepted them all, which is good. But it does put us in the queue for an analysis survey, just follow up. And then I have a sample of some of those audits that we do to make sure that we are staying in compliance with some of those things that some of the findings. This is our STERRAD audit compliance. They're doing a great job. This is, really great job. Next slide, pain audits. There are some of these audits that are going to be able to wrap up just because they're hitting that benchmark that we said we wanted to hit. And this particular slide, the compliance with physician orders will be able to discontinue those audits, which is nice. It alleviates some of the work that we have to do. Suicide risk audit compliance. This audit is a very complicated audit, and we're continually looking at it to try and make it easier to do. I'm working really closely, or actually, Kirsten is working really, really hard to bring these numbers up. And actually, February looks really good. We're at 84% compliance, between 84 and 86%. There's lots of different parts to this audit. There's a safety assessment, that's a physician assessment. There is documentation that nurses do. There's documentation that sitters do. And all of this has to kind of come together. So lots of moving parts, room for improvement here, but I know that Kirsten is working on it every day. And then our compliance with interpretive services. I think overall we're doing good. We're bringing that number up. We're doing some legislative work, just catching up on some legislative changes that have happened at the state level that impact our hospital. So just, I mean, we all know that the state always does new bills. They're always doing new things, and oftentimes they impact us here in healthcare. There's a couple of resources that we use to kind of stay on top of these changes. We use the California Hospital Association and CDPH. They do their California Health Alerts that help kind of keep us abreast of what's changing. We look at these changes and we decide, is it going to impact us? And if it is, are we in compliance? And if we're not in compliance, what do we need to do to get there? So some important things to think about is that oftentimes these changes are improvements to often meant to improve the care and conditions for patients and or staff. Some implementing reporting requirements that we have to do to the state. So sometimes we have to take that information and start doing reports. And then a violation can lead to penalties and fines. So right now what we're doing is we're tracking about 19 bills that have changed. Of those 19, 3 of them we decided were not applicable. They didn't apply to us. 2 have been completed, and then we have 14 in progress. We're meeting with people on a regular basis to just make sure that we're in compliance. Next slide. Risk management and event reporting. So we recently had the great luck of being able to hire a risk manager, and she is working our event reporting. So whenever there's an event that happens in the hospital, we have a system called VERS that kind of tracks these events. For the month of December, we had a total of 88 incidents that were reported. 95% of those incidents were actually closed, which is great. She's working them. She's making sure that the investigations are done. 5% are still open. When you look at this, you can see 3 East is by far the most frequent reporter. And she says that's either indicating that they're having a higher rate of incidents or they have a better culture of reporting. So that's just something that will remain to see. We're keeping an eye on that. And then some of the top risks are medication and other substances, admission, discharge, and transfers, and then device-related issues. In addition to Tanvir, we also have a new employee health nurse that is looking closely at our employee health program. With regard to injuries and workers' comp, she's working real hard to reduce some annual spend around some of our employees that are on light duty. Just looking at them and making sure that we can do our very, very best to bring them back in and do some work at a reduced light duty. So they're not doing their normal job, but they're helping out and they're in the hospital, and that ends up saving the hospital money. She is also case managing a lot of our workers' comp claims. She has the agile physician on speed dial. They talk regularly about the cases, and she's doing a good job just case managing them and making sure that the employees are taken care of and the hospital is being taken care of as well. So she is tracking, she has a new expanded sheet that she's using to track some of the things that go in and out of her office so that she can do a little bit more analysis for improvements. And then finally, one of the other improvements that she's done is with hiring onboarding new hires. She is proactively asking them to bring in or send her the screening stuff that she put screening stuff. The screening stuff. All of like the TB reports that they have to do and the health screening, all of that stuff. She gives them to bring those proactively before they even come on site. It helps make the process much smoother. And then I already mentioned the tracking system. At the staff office. Just at a really high level for Q4 new appointments, we had 8 in October, 19 in November, and then 21 in December. And the other thing our med staff office has been working really hard at lately is collaborating with our Director of Strategy and Program Development to transition a new anesthesia group as of 2/1. They worked really hard behind the scenes to make a pretty seamless transition. A lot of good work going on there. Next slide. And this is just kind of a breakdown of the number of providers that we have by department. Medicine looks like it's a little bigger, and it is bigger. It does include our anesthesia group, and it also includes our tele-neuro specialists, which there's a big bunch of them. Healthcare acquired conditions. This has not changed. Very proud to say, as of the date that I made this slide, 315 days without having reportable events. Good. Infection prevention. This slide is Monica, our infection preventionist, is spending a lot of time rounding on the units and watching. And if you look at the slide, the graph on the left is basically what we have nurses on the units, or people on the units, not necessarily nurses, that kind of do their own observations and then give that information to Monica. And that's what they report. And then the information on the right is what she's actually observing. The N is very different. There's a much lower number of observations that Monica is doing, but we're going to be watching this really closely to see if this variation continues. And she's already identified a difference in the questions that she asks versus the questions that they ask. And I think they're already adjusting that so that they can be looking at the same pieces of information. Quality metrics. I think last time I was here, I talked a little bit about these slides. So readmission rate, we're doing great when we look at ourselves compared to other California hospitals. Mortality, again, we're doing really great compared to other California hospitals. The next slide is mortality as well, but it's just sepsis mortality. A little bit higher here. And then social determinants of health, which I'm sure we're not surprised that we win at this point right now. So we have a lot of people that come here and have needs. This is normally Steve's jam. He let me present this time. So I want to talk a little bit about response rate. If you look at the blue bar, that blue bar is a benchmark that CMS kind of puts out there for us. And the yellow bars are our actual response rate. Why is that so important? It reflects, this information reflects the participation rather than any kind of meaningful patient experience. But increasing that volume will improve the data stability and the comparability. So it's an important thing to track. HCAHPS overall patient satisfaction, still a little bit down from last year. And that's about rating the hospital from 0 to 10 and just overall.
Recommend.
Yes, recommend the hospital, thank you. Communication, next slide. Communication with nurses is looking pretty good. Communication with doctors also looking very good. The hospital environment, so that's how loud are we and how clean are we? The cleanliness is a little bit lower than what we were last year, and the noise level is lower, but not as. And then communication about medication is also increased. And then I want to talk a little bit about the CMS star rating and kind of tie it into our quality improvement project for 2026. So the CMS star rating is how CMS assigns hospitals star rating, stars, right? 1 through 5, based on performance across multiple quality measures. This information, the star, is published on Medicare's Care Compare website. And the purpose is to help patients quickly compare hospitals. Slide. Actually, go back one, please. Never mind. So measures are grouped into 5 domains. Mortality, the safety of care, readmission, patient experience, and timely and effective care. So those are the 5 domains that they kind of look at. Slide. So CMS collects hospital data, performance data. All of these measures are combined into domain scores, and then those domains are weighted and blended into one overall score. And then based on the overall score, the hospitals are placed into that 1 to 5 category. One thing that's important to note is that each of these measures has a different look back period. So CMS uses varying data windows because some of the measures require a longer look back for statistical reliability, while others update faster. This means the overall star rating reflects performance across different time frames, not a single moment in time. So right now, our star rating is 1. So we have lots of room to improve. So this score is not an accreditation score. It's not a full measure of safety or excellence. And hospitals with the same stars may perform very different. Leads me to my next and final slide. So we need to have a quality assurance, a quality improvement plan for 2026. And the Joint Commission in 2026 came out with Accreditation 360, and basically Accreditation 360, when it comes to this improvement project, they want us to incorporate the whole entire hospital. So trying to include several domains versus in the silo, I'll get med-surg's quality improvement plan, and I'll get radiology's quality improvement plan. What they're saying is we want you to work together to kind of improve to improve. So my recommendation at today's QPSC meeting was that we work toward improving the CMS star rating. And we all came to an agreement that what we're gonna do is focus on improving the number of HCAHPS surveys that we get back, that we can up that number, hopefully we can get some more. That's where we're starting. We're starting with that. That's it.
Good.
Question.
Cool. Any questions? Joe?
Can you give me an example? You said that the CMS star rating, various parts of it go back varying periods of time. What's your sense of how long ago this 1-star rating comes from? 2-3 years, or?
To be honest with you, I don't know the specifics about that, but I know that they do look back for some things, probably, I would imagine, between 3 and 5 years.
3 to 5. And then the other thing in terms of the survey response rate, is that for HCAHPS surveys, or is it? Okay, thanks.
Yeah, any other questions?
And we've had, so thank you. No questions here, just more of a setting the context. I mean, the star rating is something we had early discussion in 2025-ish. And I guess I'm touching on how does that compare and contrast versus Leapfrog that was shown as, and Leapfrog at the time, late too, but it was a D, the C, the B, and then this year we're so close to an A. Like, we compare and contrast, like, what dictates that progress, which is very meaningful to us, and the HCAHPS progress, which is very meaningful to us, yet the star rating is so much lower than where we're currently at. Does that make sense?
Yes, it does make sense, and I think that and I've not actually done the whole entire Leapfrog survey. I've not completed one. But my sense of that is that there's a lot of questions that we answer. I know that there is some data that they look at. A lot of those questions are answered by the hospital. CMS gathers all of this information from various places that we submit our data. And the look back, I believe the look back for CMS is probably longer than what it is for Leapfrog, if I'm not mistaken.
Yeah, that's right. You got all that right. The Leapfrog is a combination of sort of self-reported, are you doing this? How are you doing this kind of questions, as well as some publicly reported data, which is why you'll see some hospitals don't have a Leapfrog score because they don't participate in the self-reporting part of it. And the self-reporting part of it is things that are more in our control, right? We can see what the question is, and is it a yes or no? And if it's a no, we can be like, oh, well, if we do that, we'll get some Leapfrog points, right? That's not the case with CMS. And yes, the CMS data tends to be a lagging indicator. So we've always known that this has been 1-star for this hospital for as long as I can go back and find publicly available data for it. And we've always known that once we get Leapfrog in the right trajectory, this was the next thing to follow.
And just as a side note, the way that we get the response rate from the HCAHPS scores is immediate. It's separate from the way that CMS. Yeah. Okay. Just want to make sure that you guys understand. We'll be able to have we'll be able to do interventions and then be able to immediately see if we're making.
Yeah, we can see patient experience data as soon as it's entered into the database. It won't actually impact our CMS score for probably 30 months. By the time they actually sort of catch up to their publicly reporting of all of the hospitals across the country.
If we can start moving the dial or dots, whatever, start moving it a little bit toward the right direction, eventually that star will come.
Yeah. And then I want to believe the progress we made across the HCAHPS, like even you showing in this slide the 4 years of review, first few years, almost for every slide is really low, and then 2024 was a really strong year, and then 2025, I guess, by income issue that led to that a little bit, but 24 and 25 are way better than the 22, 23. Yeah. So I've got to imagine that those HCAHPS scores will also start flowing into that star rating review as soon as
Yeah, the patient
That's your-
experience, the whole domain. of patient experience.
So I have a question then, and I might have missed it. So the plan, the improvement plan, it's more than just increasing the number of responses. Is that right?
What we're gonna focus in on is just increasing that number of responses, and there will be various ways that we will try and do that.
But not focusing on what the measures are showing to improve, because we had some areas that went down. I guess when I think of an improvement plan, I think of not just a survey response, I think of the actual activities that we're doing. And you had highlighted a few that you had been working on, but then I did notice, I was taking notes, now I can't find it. Oh, like overall patient satisfaction is down. So is there a way to drill down into that to support? I guess I just, when I think of an improvement plan, and I could be wrong, it's just that there are other indicators that the hospital, you said, working with the hospital. So what feedback is being given to them to make sure that they are improving their services? Does that make sense?
It does make sense.
Okay,
So a lot of thought from me went into this idea. And part of it is, right now, our leadership team is busy. It's really, really busy, and trying to have them shift culture right now, which some of this is around culture, is a big ask.
So my question's on in terms of bringing in additional survey responses to this, we feel like the additional survey responses will give us a better measure that we can then work off of that when we become more stable, or do we feel that maybe it's both that
The data will be,
the data we feel like the majority of people are getting good care here, and if we get more survey responses, then it'll trend in a better direction, or is it a little bit of both, or what's
if we get more, if we get more responses, it could go the opposite direction.
Mhm.
That's not what we're anticipating, but that's what can happen. Getting more responses it increases the reliability of the responses that we are getting.
Mhm. Yeah. Understood. Any other questions? I have just one more question, but I want to go back a couple slides. Can we go back to the slide on the social determinants of health? I just wanted to figure to know.
So big slide.
Yeah. How do we pull that data? Is that something that we collect? I think we just got to say. So is this something we collect through like the area served, or people who have visited the hospital, or how is this?
It's based on patient interactions. So these questions are asked. I'm not quite sure where in the continuum they are asked, but
Sure.
yeah, this reflects the needs of our patients that are coming through our.
So our patients are filling out a survey that goes into the HCAP survey, and that's how we're getting that data?
No, this is part of the patient intake process.
Oh, I see.
Yeah, okay.
And this is not.
Not part of the patient experience, HCAPS.
No, yeah. This is part of a website called HQuip. And they collect information from a lot of different hospitals in California.
So we have the intake staff or the nursing staff, depending on the question, will ask these questions of the patient. It goes into the electronic health record and gets uploaded to HQuip, and then we can download our aggregated data.
Understood. Yeah, it's not surprising, but always striking, I think, in these things.
It is.
So it's, really tells a story of who we're serving on a daily basis. Please, of course.
I also think the importance of keeping this hospital open. We're assuming, how that would impact the community and these residents.
And this was just through September of 2025. So it'll be interesting to see what happens.
There's more
this year
impact.
unfolds.
Okay, I don't have any other questions. I do want to open up to public comment, but one more question.
Rosie, if you can,
Oh,
sorry.
sorry.
Didn't catch it, that's it. You still have the slide deck where it is.
Yep.
Two slides forward, the benchmarks for the survey response rate. How do we, who are those benchmarks for those data?
CMS, they give us those benchmarks.
Is that what we would aim for? Or are we still establishing what we,
No, we want to aim for those. Yes.
great, thank you.
Okay. No, I think that's it. Thank you. Okay, I am gonna take public comment on this. Anyone online wishing to speak on this report? Okay, seeing no hands raised, anyone in person? All right, I'll close down public comment and thank you, Michelle, for the report. And I'll move on to item number 8, short-term loan agreement with the Community Health Trust, Colorado Valley. We have a recommendation before us is to one, pass a resolution authorizing the execution and delivery of a loan agreement with the Community Health Trust of the Colorado Valley in the principal amount of $2 million. And 2, authorizing the CEO and CFO to execute and deliver the loan agreement and all related documents on behalf of the Healthcare District Hospital Corporation, also there's one community hospital. Steve?
Yeah, so this is good news, and I want to publicly thank the Health Trust, DeAndre James as the executive director, and their board. I've worked closely with all of them on this, and they are familiar with the things that we talked about earlier in the program about some of our cash shortfall challenges, the challenges of delayed and canceled reimbursement from our government, and have stepped up to offer us a short-term loan of $2 million that will help us with our operating expenses, and we will be able to pay this back. We should get this delivered to us in sometime in March, and we'll be able to use it for that period of time. And then in June, when we get our intergovernmental transfer program back from the private hospital supplemental program fund, we'll be able to pay them right back, and we'll keep the balance for our own operations. So it is a short-term, no interest paid to them in the first month, and just a little bit of interest for the remaining probably month and a half or so that we'll have it before we can pay it back.
Any questions about this?
I've been sprinkling in my comments today, I feel like they're sneaking out of me, sort of. Just our ask of our partners to help us through this moment, and this is a great example. I'm so proud of Community Health Trust, DeAndre, and their board, stepping into this moment and stepping into it with a really strong commitment to helping us. So just DeAndre, wherever you're at, and your board, wherever you're at, if you're watching, I know maybe you'll watch this on pay-per-view. Just thank you very much on the part of all of our partners. We appreciate you and your board's efforts to bring this forward.
Okay, any other questions? Do you need to take public comment on this? Anyone wishing to speak on this item online? Okay, anyone in person? Okay, seeing none, I'll bring it back for any comments and an appropriate motion on item number 8.
I will move to approve the resolution.
Second.
Thank you, Directors Friel and Gallagher. I'll take roll on this item. Director Friel?
Yes.
Director Gallagher?
Yes.
Director Kurtenbell?
Yes.
Yes. Okay, we'll move on to item number 9. This is this is the formation of CARE, the Community Access to the Responsible Evolution Ad Hoc Committee. There is a recommendation before us to pass a motion to form the Watts Hole Community Hospital Community Access through Responsible Evolution CARE Ad Hoc Committee of less than a quorum of board and appoint a committee chair. And I'm bringing this item forward with the help of Steve. So given the conversations that we've had over the last few months about and the conversation that we had today throughout today's meeting, I thought it was a good next step for this board to form an ad hoc committee that can continue those conversations outside of our regularly scheduled board meetings, both with the administration and then also with our partners and staff about what are the next steps in terms of short-term decisions that will help put the hospital on the right trajectory that can get us to what we have all been talking about as a potential horizon where we see funds coming both from the federal government, from a delayed program, and then also from potentially a state budget allocation or additional assistance through the rural health transformation program as well. And so bringing this item forward to form this ad hoc committee. I am all ad hoc committee out. I serve on several of them and regrettably do not have time to serve on this committee. But my recommendation would be, if I had to make one, is to appoint Director Pimentel as the chair of the ad hoc committee, and then go to my fellow board members to see if there's support for that, and if there's anybody else that would like to join Director Pimentel on that committee.
I would recommend.
And so that's a recommendation I bring to this board, and obviously any questions for me and then for Steve as well as to the forming of this ad hoc committee and the responsibilities as those.
Questions and comments? The question. It isn't a question. I'm coming up with
lots of comments.
My recommendation is that this ad hoc has kind of a dual purpose. One is we have a very short-term acute issue of solving for cash so that we don't have things we're starting to see happen. I like that. My recommendation would be that this ad hoc is really focused on the short-term things we must do, to your point, to make sure that we are here in March, April, and May in our best selves, not in we're pulling back selves. Realizing that pullback might be important, but we have to have those conversations. But I'd like the ad hoc focus. I appreciate, I guess, the comments. I appreciate how well thought out this recommendation is. I think it would do a lot of things, and my primary concern is the next 3 months. How do we focus on the next 3 months, and then have the ad hoc discuss, maybe make a recommendation about what's next after that? What does it look like after we've solved for that? And I'm using 3 months next because an illustrated example might be 4 months, that we have a very short-term focus versus solving for the short term while also planning what 2029 is going to look like. I think it's too big of an effort and lift, and you would end up with competing things we do in 2029 could be different for the next 6 months. But I'd recommend that the ad hoc is focused on very short term, and that this ad hoc report back next month and make sure we're in agreement on that, and we can see if that resonates with the board.
Yeah, I agree, and I think the purpose of the ad hoc committee was allowing the board to appoint 2 trusted members to start those conversations with the administration, and then also come up with a plan of how we are going to work with our community partners to continue the conversations that we've been having, that we talked about earlier in this meeting. There's a lot of work that needs to be done at this moment with our local and state representatives, and also with our partners within the healthcare industry as well. And so, my goal was to, at this moment, hand off some of that work to of my fellow board members who can carry that work along with the administration, and what are the next steps that we do, and ideally come back to this board with exactly that in March, and come back with a report of what the first month looks like, and look like the work of that, and what would the next steps be in the short term. And then at the end, when this ad hoc committee were to close down, is not necessarily to say, this is what we're gonna look like in 28 and 29, but these are the next steps that we should take to set up, you know, the process of determining that, whether it is, you know, potentially looking at our strategic plan again in a year or so, or something like that, just sort of recommended next steps for winter. Any other questions? Oh, it's, looks like
And what I would say is, my expectation is, we're not waiting until the next board meeting to act.
right.
We're coming back to the next board meeting with a refined recommended scope, while we're also working with staff on just those efforts.
Mhm.
I hope we have the bandwidth to start doing the work.
Mhm.
So that would be my expectation. It's not wait a month and then start doing kind of both in parallel.
Yes, definitely, yes. Thank you for being open to being voluntold to do this. So, you don't have a lot, going on at work right now, the county budget looking really.
Sarcasm, sorry.
Yes. So I have a recommendation for Director Pimentel to serve as the board chair or as the committee chair. We have interest from Dr. Gallagher. Alex, any interest of serving on the?
I mean, I am for sure, but I will defer. Dr. Gallagher responded first, so that's fine.
Okay, any other questions for me or for Steve about the ad hoc before I open up to public comment? Okay, then I will open up for public comment. Anyone online wishing to speak on this item?
No hands on mine.
Okay, anyone in person wishing to speak on this item? Okay, then I will close the public comment. I'll bring it back to the board for any further deliberation and also for an appropriate motion if there's.
Move approval.
A second. Yeah. So Noelle, I see you unmuting.
Yeah, I didn't hear in the motion if there was two board members who were suggested to be on that committee.
Yeah, so just to be clear, the motion, go for it. I didn't think you should. Well, let me pitch what I had said. We're supporting the recommendation that I will serve as chair. Dr. Gallagher will serve as a member of the ad hoc. We'll work in parallel with developing the scope of the ad hoc and report back to the next board meeting while also working with staff on some of the early measures we can start working on.
Sounds good. So that's the motion.
Yes.
Okay.
Yes.
Thank you. I have Directors Gallagher and Pimentel. That motion in a second. I'll take roll on this item. Director Friel?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
And Chair Newman?
Yes. Okay, that brings us to the end of the Watsonville Community Hospital meeting.